They're using the most effective drug first.
And Anne, you take care of so many breast cancer patients. I know do a lot of second opinions at your practice. Tell me about the patient coming in. How are you going to have this discussion with that patient?
I think we're absolutely obligated. I mean, anytime we have something with, median progression-free survival of 40 months, a 15% chance for a complete response, we absolutely owe it to our patients to discuss that option with them. I think absolutely looking at how that patient is coming to us. Do they already have neuropathy? Does the patient have really significant or even moderate diabetes to where incorporating steroids with the taxane is difficult for them? These are all considerations. I know it seems trivial, but hair loss, is many of these patients may be either de novo or they may have had a 4, 5, 6 year treatment-free interval. They've just gotten their hair back. They're very excited to keep that. And so that's, something that we have to discuss as well. And I think when we're talking about, quality of life for them, it's really a discussion about what does life look like on T-DXd compared to a taxane, trastuzumab, and pertuzumab, and what are the pros and cons of that? And I think for me, it's talking with them about what gives us the best chance to get the deepest response, right, initially.
And that's what I often hear. I hear, use your best drugs first. And I've also seen data presented in HER2 positive disease that maybe, a third to a fourth of patients who get first line therapy might not go on to get second line therapy. So talk a little bit about that philosophy, I guess, of using sort of the most effective drug first.
I think for us, definitely in the HER2 positive space, is when we know there's a propensity for central nervous system metastasis. I think this is the place where using that first drug first absolutely makes sense, or using the most effective drug first is absolutely what makes the most sense, what's going to give us the deepest, most durable response. And then certainly weighing that with quality of life. I absolutely have seen those data sets as well, that we might lose, a significant number of patients that go on to get second line. I think between second line and third line, we lose about half of patients that aren't able to go on for whatever reason, whether it's rapid progression of brain metastasis or deterioration in performance status, whatever that is. So to think about a patient that might miss out on the opportunity to receive T-DXd with these kinds of progression-free survivals, hazard ratios, chance for a CR, to me, that I'm not willing to take that gamble, really. Right. And so for the majority of patients, we're going to recommend this in the first line.
So definitely shared decision-making, but a lot of reasons to think this is very hopeful.